catheterization. The problem with ticlopidine and clopidogrel is, like I said, some patients clot like crazy and some bleed like crazy. We don't know which one is going to bleed, obviously due to a genetic issue there. The incidence of neuroaxial hematoma is not known. This is like the devil who will come and take away the small child who refuses to sleep at night. All of you have told your children. It is like that. We don't know. So we think, okay, if it is there, why do I want to face it? Let my neighbor do it. I'll see him in the court. So we don't know. There is no evidence. But if I say that we'll do a multicentric study on insertion of epidural in patients who are on clopidogrel, how many of you will participate? See, that answers my question. The cessation time is a little controversial. The ideal time is 14 to 18 days because the number of days required for the drug to be washed out, it's not the platelet. Every day about a lakh of cells of platelet per ml of blood is generated. You know, if you have a dengue fever, your platelet count is today 40, tomorrow 1 lakh. Platelets are very rapidly generated, but this stupid drug is so long acting that the new platelets also get attacked. So that even if you give platelet transfusion, they get tackled. So it is only by dilution that the drug goes away and the patient probably starts clotting. Therefore, the drug works for a long time, but even the ASR consensus 3 says that 7 days is a reasonable period of time. However, there is no clear-cut time limit when we should stop and when we can do a epidural catheterization. And time to normal platelet aggregation is 24 to 48 hours if the patients are on abciximab and 4 to 8 for other drugs like tirofiban. Avoidable. If you think the risk of general anesthesia is very high compared to the risk of even a neuroaxial hematoma, you can give spinal because the incidence of spinal induced neuroaxial hematoma is lesser than epidural. There was a guy called Ho who gave data saying that if you give a spinal in a patient with antiplatelets, the incidence of hematoma is 1 in 350,000 and in epidural it is 1 in 250,000. Already 2 cases of epidural hematoma have been reported. Therefore, these host calculations are not considered a gold standard anymore. However, please remember that the incidence may be lesser with spinal. However, you have to explain to the patient weigh the risks versus benefit, explain to the patient, involve them, involve the surgeon, and then do the procedure if you think spinal is the best anesthetic for him. Nerve blocks, wherever it is possible, special consent and use aids. What are the aids? Ultrasound. We are going to listen so much in the next few days. You will start hearing the ultrasound. And thank you. Nerve stimulators are supposed to be not the class 1 recommendation, however ultrasound is. X-ray guidance, if you don't have any one of them, but it will not protect you from hitting an artery. This is these are the last couple of slides. This is the year 2007 when we did about 59 joint replacement bilateral, and year 2009 or 2010 when we did 235. You can see the change in the profile of the anesthetic management. We gave a lot of epidural anesthesia when we started off, and some GA plus epidural anesthetic and blocks. Here, we have started combined spinal epidural anesthesia and a lot of blocks coming up. Spinal anesthesia also. We are doing bilateral femoral-sciatic blocks for bilateral knee replacements because the patients are on anticoagulation. There is no way we can give epidural. The epidural, in the next slide, you will see the number of the epidural anesthetic, GA plus epidural and epidural anesthesia is low, and GA plus block is on the rise. That also explains that this conference is going to be very useful. When you go back home, you can really use it on your patients. It is not like one of those just theoretical conferences. I'm sure you are going to. And what are the etiology of the neurological injury? Inversely proportional to experience of the anesthesiologist. Okay? Multiple attempts, also related to the number of years of experience. Hemorrhagic tap, don't think that you will not cause another hemorrhagic tap in a level above. How is it different? You are the same. Patient is the same. Pain on epidural catheter insertion. Okay. Now, this is serious matter. pain on epidural catheter insertion is something which you should not continue with. Epidural catheter insertion is basically pain-free. If you do get pain, if the patient gets pain, stop. Probably you are elevating a plane of the root of the nerve or the spinal cord. It's not a good idea. Patient may get injury. Hemorrhagic aspirate from the catheter, remove it, and procedure to be done 24 hours later. Uncooperative anxious patient, don't convince him how good epidural is, because the moment you put the spinal needle in the neck, high in the neck, he is going to do that, and he is directly going to guide you into subarachnoid space. So what do you do when you have a neuraxial hematoma? Identify early. Severe backache despite the block is a very, very important symptom. Patient has a block, but he has backache. Don't neglect that backache. Neurological deficits might occur later. Order a CT scan, get a neuro opinion, surgery ASAP, because this slide shows you earlier the surgery, better the outcome. Even in early surgery, some patients do not get 100% recovery. So be on the lookout if you have a problem. Thank you very much.
Momento.